Hi everyone, I'm Nikki, and today I'll be talking about the West Nile virus, the St. Louis encephalitis, and the Japanese encephalitis. I'm going to begin by talking about the West Nile virus. It was discovered in 1937, where it was isolated in the West Nile district of northern Uganda, hence why it has its name. And its first case in the US was in 1999 in New York City. It is part of the Flaviviridae family, and it's an enveloped virion containing a single-stranded positive sense RNA genome. It is the causative agent of the West Nile fever, encephalitis, and meningitis, and it's an arthropod-borne virus and is the leading cause of mosquito-borne disease in the United States. And currently, there is no vaccine available for the West Nile virus. So in this slide, we have the transmission cycle of the West Nile virus. As you can see, the primary transmission cycle is between birds and mosquitoes. Birds are the host, and they can infect mosquitoes that feed on them, and then the mosquito can continue the cycle and then infect other birds, and then just the cycle continues. But mosquitoes also have the ability to infect other animals by biting them, such as humans and horses. Humans and horses are incidental hosts or dead end hosts, meaning that they cannot pass the virus on to other biting mosquitoes, and this is due to them not being able to develop high levels of the virus in their bloodstream. Um, Human to human transmission is extremely rare. The West Nile virus cannot be spread through coughing or sneezing, so if you're in a room with somebody who has the West Nile virus, you're safe and you're not going to get infected. The only time when there is human to human transmission is in some cases, such as organ transplant, blood transfusion, or mother to baby, which is during pregnancy, delivery, or breastfeeding. So 80% of people who are infected with the West Nile virus are asymptomatic, and then 20% are symptomatic for the West Nile fever. The incubation period is typically around 3 to 14 days, and symptoms include high fever, head and body aches, joint pain, and vomiting and diarrhea. Typically, people who have these symptoms recover rather quickly and there's no damage done. Um, but in other cases, which is less than 1%, it can lead to severe central nervous system damage and could cause death. 1 in 150 of those with West Nile fever will further on and develop West Nile encephalitis or meningitis. Encephalitis is the inflammation of the brain, and meningitis is the inflammation of the membranes that surround the brain and the spinal cord. So these affect the central nervous system. Symptoms for these more severe cases include neck stiffness, disorientation, coma and paralysis, and tremors and convulsions. The groups that are at greater risk for these more severe cases include those who are 60 years and older, those with weakened immune systems, people with cancer, and people who have received organ transplants. Most people who have severe West Nile virus illness do end up recovering, but some of the effects to the central nervous system can be permanent. And 1 in 10 of those with severe West Nile virus illness unfortunately do die. Diagnosis for the West Nile virus can typically be done with a simple blood test where they test the serum or cerebrospinal fluid to detect for West Nile virus specific IgM antibodies, which can typically be detected 3 to 8 days after the onset of the illness. In severe cases, lumbar puncture, which is also known as spinal tap, is used where they extract fluid from the spine. West Nile virus elevates the white blood cell count, and so they can use this to determine if West Nile virus is there, and then in other severe cases, an MRI can be done to look at inflammation or swelling of the brain. There is no specific treatment for the West Nile virus. In less severe cases, over the counter pain relievers can be used to reduce one's fever and relieve some of the symptoms. And in more severe cases, supportive treatment can be used, which includes nursing care, pain medication, and intravenous fluids. So, because there is no specific treatment, prevention is critical, which is the avoidance of mosquito bites in this scenario. So, this includes using DEET bug spray, being very cautious when you're outside during the summer months when the West Nile virus is most prevalent, wearing long sleeve shirts and pants, and limiting outdoor exposure from dusk to dawn. Next, I'll be talking about the St. Louis encephalitis virus. It was discovered in 1933 in St. Louis, Missouri, when an epidemic of over 1,000 cases occurred. Since then, the disease is almost exclusively in the United States, but the geographic range of the virus does extend from Canada to Argentina, but mostly just in the United States. The largest epidemic of the virus occurred in 1975 when over 2,000 cases were reported in the central states in the Ohio Mississippi River Basin. The St. Louis encephalitis virus is part of the Flaviviridae family, genus Flavivirus. It is a single stranded positive sense RNA genome. It typically occurs late summer and early fall during the mosquito season, but in southern states where the climate is milder, cases can occur year round. It is a mosquito borne infection, and currently there are no vaccines available for the prevention. In the picture to the right, you can see the cases in the United States from 2009 to 2018. It is most common in the southern, western, and central states, and typically there are less than 10 cases per year. The transmission cycle of the St. Louis encephalitis virus is identical to that of the West Nile virus. The primary transmission cycle is between an amplifying host and a mosquito vector. In this case, the amplifying hosts are wild birds such as blue jays, robins, pigeons, and house sparrows, all of which can be found in both urban and rural environments. The birds develop vermemia and they can infect other mosquitoes that feed on them, but they themselves do not develop symptoms. The Kulak species of mosquitoes are the most common mosquito vectors, and they can go on and infect humans, which are a dead-end host, just like the West Nile virus. They cannot infect other mosquitoes that feed on them, but they can develop symptoms, um, and there is no person-to-person transmission of the St. Louis encephalitis through like coughing or sneezing, but transmission is possible but very rare in cases such as blood transfusion, organ transplant, or from mother to baby. Less than 1% of those with the St. Louis encephalitis virus are clinically apparent. Most go undiagnosed and are asymptomatic. The incubation period is 5 to 15 days, and symptoms include dizziness, headaches, and nausea. These symptoms typically are abrupt and then they can spontaneously recover within a week in most people, but can lead to severe central nervous system infections. And the symptoms for these include confusion, disorientation, tremors, paralysis, and coma. 40% of children and young adults develop mild symptoms. These include headaches, fevers, and aseptic meningitis. And 90% of elderly people will develop encephalitis. The case fatality ratio is 5 to 15%, and the risk of fatality increases with age. Preliminary diagnosis is based on a patient's history. Most infected individuals will provide a history of mosquito exposure in an endemic area. This usually includes them doing some sort of outside activity. Um, the enzyme linked immunosorbent assay or ELISA test is used to test serum or cerebrospinal fluid for virus specific IgM antibodies. And in severe cases, nucleic acid amplification, histopathology with immunohistochemistry, and virus culture of autopsy tissues are used, and neuroimaging and lumbar puncture are also used. And with this, the cerebrospinal fluid protein is elevated in 50 to 75% of severe cases. The computed tomography or CT brain scan are normal, and the electroencephalographic results show slowing without focal activity. There is no specific treatment for the St. Louis encephalitis, and because there is no effective antiviral therapy, supported treatment is used in the most severe cases. This includes IV or intravenous fluids and antipyretics. So, just like the West Nile virus, prevention is critical, and this means avoiding mosquito bites. Kind of like I mentioned earlier, this includes insect repellent, wearing loose fitting clothing because mosquitoes can bite through skin tight clothing, and avoiding standing water. So, the picture on the right shows a billabong, which is a breeding ground for mosquitoes, but it can also include flower pots and buckets left outside. Lastly, I'll be talking about the Japanese encephalitis virus. The first case was discovered in Japan in 1871. It is part of the Flaviviridae family, genus Flavivirus, and there are four genotypes that are currently recognized, but its origin is unknown. It is a mosquito-transmitted virus and the leading cause of viral encephalitis in Asia. It is estimated that there are 68,000 clinical cases per year and about 13,000 to 20,000 deaths per year. It is most common throughout Southeast Asia, and there are currently vaccines that are available. One in the United States called I0, which is given in a 2-dose series. But it should be noted that the U.S. is not a place that the Japanese encephalitis virus is common, and the few reports in the US have been from people who have traveled to places in which the disease is active. The map on the right kind of shows where the virus is most common, which is in Southeast Asia, but the transmission season kind of varies depending on the temperate regions, the season of rainfall, and patterns of bird migrations, and it is most common in areas where people grow rice. The transmission of the Japanese encephalitis virus is very similar to that of the West Nile and St. Louis encephalitis viruses that I talked about previously. The cycle is maintained between mosquitoes and vertebrate hosts, which in this case are primarily pigs and wading birds. Humans are incidental or dead-end hosts, and they are infected by a mosquito bite. The Japanese encephalitis virus transmission is often associated with rice production and flooding irrigation, and the transmission is seasonal in temperate areas of Asia, but they can occur year-round in more subtropic and tropical regions, often with a peak during the rainy season. Less than 1% of those infected actually develop clinical illness, and this is approximately 1 in 250. The incubation period of the Japanese encephalitis virus is 5 to 15 days, and the initial symptoms include high fever, headaches, and vomiting. In children, gastrointestinal pain and vomiting are some of the dominant initial symptoms. and can lead to more serious symptoms such as mental state changes, weakness, neurologic symptoms, and seizures, which are most common amongst children. For those that do develop the encephalitis, the case fatality rate is 20 to 30%, and 30 to 50% of survivors have permanent damage, and this can include the inability to speak, recurrent seizures, um, uncontrollable emotions, deafness, and weakness on one side of the body. Children are at the highest risk for these more severe fatal consequences due to them not having a fully developed immune system. Japanese encephalitis should be considered in those with a neurologic infection and has been exposed to an endemic country. The enzyme linked immunoassays used to test for Japanese encephalitis virus specific IgM antibodies. This is done by taking a single sample of either serum or cerebrospinal fluid. Lumbar puncture is also used, and then CT and MRI scans are used to see if there is a case of brain encephalitis. There is no specific treatment for the Japanese encephalitis. In severe cases, supportive treatment is available, and this is to control symptoms and prevent complications. Prevention is critical, just like the other two diseases. Vaccination is available, personal protection against mosquito bites, and then because children are at higher risk, a couple of tips is to cover strollers and baby carriers with netting, and to not use repellent containing oil of lemon, eucalyptus, or paramethanediol on children younger than 3 years old. And then these are my references. Thanks for watching, and let me know if you have any questions.